Hello everyone, welcome to this session where we will go over some classic examples of entities encountered in gynecologic pathology. We will list the logic for why we reach a certain diagnosis, give diagnostic clues, we will discuss differential diagnosis, and we will talk about clinical relevance of our diagnosis and the role of ancillary testing. I want this session to be as if we are sitting together, looking at the slides together, reaching diagnosis together. So try to follow me and hopefully you can get ahead of me and make up in your mind your own diagnosis or differential diagnosis before I actually tell you what I called it or what I thought it was. Okay, let's go. The first case is a 62-year-old with history of rectocele, and she has a labial lesion. You can see the lesion here is serially sectioned. On this power, I think the most important thing is to make sure that the epidermis doesn't have dysplasia. I don't see mitosis. I don't think there is cancer here. But the main abnormality is that the upper dermis is occupied by these cystic structures. From this power, you can see that they are not really touching each other, lined by a couple of cell layers. Many of them have the classic comma shape that we encounter in syringoma. So it will be nice to call this vulvar syringoma, which is a benign eccrine duct neoplasm. This patient just gets excision of her lesions and she will be fine. The next case is a 59-year-old with a 7.8 centimeter pelvic mass. And here is the left ovarian mass. From this power, I think you can appreciate that the cells are arranged in a nodular pattern. There is some nodularity to the lesion. From this power, could this be a carcinoma? I don't think it's a carcinoma because it doesn't form glands and the nuclei are not atypical enough. There is no loss, there is no fragmentation of tissue that we typically see in high-grade serous carcinoma. Could this be a germ cell tumor? I don't think so because this patient is too old for that. So most likely we are in the category that is called sex-cord stromal tumors, like thecoma. Could it be Sertoli cell tumor, or it could be a granulosa cell tumor? On the left, we see the tumor forming some tubules. And I just want to highlight that just because I see tubules, that doesn't make it a Sertoli cell tumor. In the middle, you can see the stroma is separating from the cell nest, giving this classic appearance that it looks like islands in a sea or in an ocean. We call that the insular pattern. On the right, you can see some attempts at rosette formation, classic cold exonar bodies. So I think this variation of the morphology is good for the diagnosis of granulosa cell tumor. Here on the left, you can see nice rosette bodies and cold exonar bodies. You can see some nuclear grooving, classic coffee bean appearance. And for those who like special stains, on the right, you have reticulin stain, which highlights reticulin around the nests and not around individual cells, which is the differential diagnosis from thecoma. So this will be diagnosed as adult granulosa cell tumor, and since the tumor is localized to the ovary, it will be stage 1A. Next case is a 44-year-old with abnormal bleeding, and pelvic sonography showed endometrial polyp, and we have a curettage here on the right. You can see many fragments of the endometrium. Some of them actually look polypoid, don't they? On the left, you can see some mitosis in the glands, so these glands are proliferative, and the stroma is a little bit busy. Cells are plump or pre-decidualized, which is what we classically see in benign endometrial polyp. In the middle, you can see that the stroma is blue in some areas, pink in other areas, cellular and hypocellular. That variation in the density of the stroma is very classic for benign endometrial polyp. On the right, again, I can see the polyp and I see a nodule of myometrial fiber. What does that mean? I don't think it means anything. Just because we have myometrium doesn't mean that the patient has leiomyoma. If sonography didn't tell me that she has leiomyoma, I am not going to make a diagnosis of leiomyoma. So I'm ready to make a diagnosis of benign endometrial polyp. What is missing? One more feature I have to see, which is the thick-walled blood vessels. I think we have blood vessels and they are arranged in a linear manner. So I have everything I needed to make a diagnosis of benign endometrial polyp. What am I going to do with the glandular crowding here? Nothing. Benign endometrial polyp is supposed to have glandular crowding. That doesn't make it hyperplasia or atypical hyperplasia. Next case is a 66-year-old with hypopigmented lesion in the right anterior vulva. Patient's images are readily available to us in the electronic patient's chart. And you can see here on the right, there is an area of hypopigmentation. This is where the biopsy came from. I think on the left also there is an area of hypopigmentation. But more important than the hypopigmentation, I think you can appreciate that the skin is thin, it is tight, and it is shiny. These are classic features of lichen sclerosus. They did a punch biopsy, you see here on the right. Here is the epidermis, and you see the upper dermis has inflammatory cells that are separate from the epidermis by an area of hypocellularity. You can see here hyalinization and hypocellularity. So this would be good for lichen sclerosus. Is there dysplasia? No, because if there is dysplasia, there has to be atypia of the basal layer, and I don't really see that. So the natural history of this entity is that this is a result of low estrogen. Now she has lichen sclerosus. If that progresses over time, there will be p53 mutation, and that will lead to differentiated VIN or DVIN, which leads to squamous cell carcinoma. I think our patient here doesn't have DVIN, she just stops at the level of lichen sclerosus. What are they going to do to this diagnosis? They will give her estrogen. Next case is a 68-year-old with postmenopausal bleeding. The biopsy was called endometrioid adenocarcinoma FIGO grade 1, and now we have the hysterectomy. I think if you look at this power, you can see the glandular crowding, and I think you will agree with me that this is good for endometrioid adenocarcinoma FIGO grade 1. This pattern could be problematic for some pathologists who would say, how am I going to make a diagnosis of adenocarcinoma if the glands are not really preforming and they are not touching each other? I understand that, but the answer to that is that look at the stroma between the glands. The stroma is pink. It is collagenized because there is fibrosis, and that tells me that there is invasion of the stroma. So this pattern of invasion would be difficult to appreciate. In the inset here, you can see cancer is in the outer half of the myometrium. So if this is adenocarcinoma in the outer myometrium, this would qualify to stage 1B. And I hope you will agree with that. But wait a second here. If you look at the inset, we are looking at the outer myometrium here, and the outer myometrium shows many spaces, and these spaces have malignant cells in them. Let us count them: 1, 2, 3, 4, 5, 6, 10, 15 maybe, or maybe 20. I have 20 lymphatic vascular spaces that are invaded by malignant cells. Why am I counting them? I'm counting them because the new classification, the new staging of endometrial cancer depends on the number of lymphatic vascular invasion. If they are less than 4 or more than 5 or more. You can see here the staging and how the number of lymphatic vascular invasion can influence staging. And I think our patient here fits in this category, which is substantial LVI of a non-aggressive histologic type. So you can see that she went from stage 1B to stage 2B. So counting lymphatic vascular invasion in the hysterectomy is very important in staging endometrial cancer. Next case is a 63-year-old. She had a history of VIN3 that was diagnosed on a biopsy, and now you have the wide resection. You can see the serial sections of the specimen. And on this power, I think you would appreciate that the epidermis is very cellular. The nuclei are atypical. They are touching each other. There is loss of polarity, and there are mitoses, and the mitoses are going all the way up into the upper third. More importantly is that there is no stromal invasion So this will not be squamous cell carcinoma. I think this will fit the diagnosis of VIN3, and that is what I think I would call this. But as I make this diagnosis, I want to remind everyone that every time you make a diagnosis of VIN or CIN, that is HPV dependent. And that is a sexually transmitted disease. So when we make diagnosis of VIN or CIN, we are telling the patient that she has a sexually transmitted disease. And this is heavy. This is really, really important. And I have seen this diagnosis breaks patients. This diagnosis can break a patient, can break families. I have seen cases of divorce. They are getting divorced just because the pathologist called it VIN or CIN. And why did the pathologist make that diagnosis? I see pathologists overdiagnose dysplasia. They overdiagnose dysplasia because they say, well, I want to protect myself. I don't know, because they don't know. I think it is VIN1 or maybe 2. They think that this is a mild diagnosis. I'm not calling it cancer. So they think this is a very mild diagnosis they can give the patient. Absolutely not. This is a very, very serious diagnosis because of its social connotation. Next case is a 58-year-old with postmenopausal bleeding. The biopsy was diagnosed as high-grade malignancy. They went ahead and did a hysterectomy. And here in this section, this is upside down. So you can see a polypoid mass here. On the right, you see the tumor, and it is hardly invading into the myometrium. Here, you can see the polypoid mass. I think the stroma is very cellular. We have some glands entrapped in the cellular stroma, but I think you would agree with me that these glands are benign. They are normal. The problem is in the stroma. The stroma is very cellular. So what could this be? Could it be lymphoma? Maybe. Leiomyosarcoma? Maybe. Endometrial stromal sarcoma? I think that's a better diagnosis. It's not leiomyosarcoma because leiomyosarcoma typically has thick-walled blood vessels. Look at the blood vessels here. They are thin-walled. You can hardly see them. They are like small capillaries. So this is a very cellular tumor, but more importantly, it has these pink fibers. These are collagen fibers. We call them collagen plaques. Collagen plaques are classic for endometrial stromal sarcoma. Yeah, I see mitosis here or mitosis there, a couple of mitosis here or there, 5, 10 mitosis, it doesn't matter. It is still going to be a low-grade endometrial stromal sarcoma. Why it is low-grade? Because there is no nuclear atypia. Nuclear atypia is not marked. Here is another field. It shows slightly different morphology. It shows more mitosis, I understand. But again, the nuclei are not atypical. It is not fragmented like what you see in high-grade endometrial stromal sarcoma. So I think this would be a good, low-grade endometrial stromal sarcoma is a good diagnosis here. For those of us who like immunostains, CD10 is positive in this case. In my opinion, CD10 is a completely useless stain. It's very non-specific. I don't do it, but you can do it if you like it. So this will be a low-grade ESS, and since the tumor is less than 5 centimeters, it will be called stage 1A ESS. Next case is a 46-year-old with atypical glands shown on PAP. They did ECC. The pathologist called it atypical cells suspicious for AIS. So they went ahead and did the leap. And here's the leap. You can see ectocervix, you see endocervix, and here's the transformation zone. I think this is the area that we will need to look at. I think this piece is fine. This is the area where there is an abnormality. It is slightly blue. It is slightly busy. You can see that some of the glands are involved partially by malignant cells, but malignant cells do not involve the entire gland. And even when the entire glands are involved, the glands are still arranged in lobules. Here is a lobule, another lobule, another lobule, another lobule. So it is lobulated neoplasia. So I think that fits very well with the diagnosis of AIS or adenocarcinoma in situ. I have mitosis, I have apoptosis, and more importantly, I have these nuclei. I want you to spend time looking at these nuclei. They are tall, they are elongated, they are darkly stained. You cannot see chromatin details because that is the differential diagnosis from endometrial cancer. In endometrial cancer, the nuclei are round, the chromatin is open and it is coarse and you can see through. Here you cannot see through because these nuclei are loaded with the viral genome, so they are darkly stained. Here is higher power. You can see the tall nuclei jumping on each other. You see mitosis, apoptosis, and since they are lobulated, I think this would be an AIS, HPV-dependent associated AIS, and the margins are negative. Next case is a 71-year-old postmenopausal bleeding. Well, she had a hysterectomy, and the left ovary here has a 1.6 centimeter tumor. You can see in this section, again, you notice the nodularity, how these cells are arranged in vague nodules. Again, I don't think you can make anything malignant out of this. It's not carcinoma. I don't think it's a germ cell tumor. I think we are still in the 6-cord stromal tumor. From this power, you can see a couple of patterns here. You have individual cells, you have small clusters. On the right, you see arrangement in cords, but more importantly, you see between the cells, there are small capillaries that are filled with red blood cells. So this will be good demonstration of an endocrine active tumor. This tumor is secreting something. It is secreting steroid. And here's the classification of steroid cell tumor. I think since we don't have any of these histories, I think we are in the Leydig cell category. And here is high power to highlight the round nuclei. They are very monotonous. Each one has a prominent nucleoli because there's a lot of RNA. They are manufacturing steroids. And between the cells, you have these capillaries. The cytoplasm has these fine secretory granules. So that will be an example of a Leydig cell tumor. This is an 82-year-old, and she had a right vulvar biopsy that was diagnosed as DVIN, and this is the wide excision. You can see here that the epidermis, I want you to notice that the upper epidermis is pink, but the lower epidermis is dark because these cells, the nuclei are prominent. This is what we call basal cell prominence of the nuclei. You have individual cell keratinization, you have mitosis. So I think this patient went into DVIN, and here is the lichen sclerosus as we saw in the previous case. So the difference between the previous case and this case is that this case has prominent of the basal layer nuclei, you have mitosis, and you have pallor of the upper dermis, but the lower dermis is darkly stained. Again, you have individual cell keratinization, and you have the nuclear atypia, you have the mitosis. So I think this patient progressed further from lichen sclerosus into DVIN. This is what you need to see to make a diagnosis of DVIN. This case is a 52-year-old with a 3.6 cystic solid tumor of the right ovary, and she had an excision, so you can see the cellularity here, and here is the wall of the cyst. Let us start by looking at the wall of the cyst. I always say the first step in ovarian tumors is to determine the cell type, the lining of the cells, the epithelium. I don't think this is serous. I don't think it is mucinous. I think it looks more like endometrioid. And we have hemosiderin-filled macrophages here. So I think this is a good focus of endometriosis. From that endometriosis, we have this cellular tumor. So this would be an adenocarcinoma. I'm calling it adenocarcinoma because we have the cribriforming and we have the squamous differentiation. So this probably will be a good example of endometrioid adenocarcinoma, well differentiated. It is not serous because I don't have the nuclear atypia. It is not mucinous because I don't see mucin. This case is a 64-year-old with slightly high BMI. She was diagnosed as endometrioid adenocarcinoma, and I think you can appreciate here the adenocarcinoma invading again into the outer half. Diagnosis of adenocarcinoma is easy. I just want to focus on this area here where you can see the tissue is fragmented with inflammatory cells. The stroma is very desmoplastic, and you can see cystic changes and a lot of inflammation and fragmentation. That is known as a microcystic, elongated and fragmented pattern of myoinvasion. Why this is important? it is important because it is typically associated with lymphatic invasion. And once you see that, it is very important to do cytokeratin on the lymph node, because I guarantee you the lymph node has isolated tumor cells. You see them here, or ITCs. You cannot see them on H&E. You have to do immunohistochemistry to see the ITCs. So this is a list of all the cases we discussed today, and I thank you for being with me. And here is my email. Please send me questions about these cases or anything else in gynecologic pathology. Thank you.